to introduce our DMEC speaker, Dr. Marshall Jr. Dr. Marshall is the R. Fraser Triplett Senior Chair of Allergy and Immunology, Professor of Medicine and Pediatrics, Vice Chair for Research in Internal Medicine, the Director of the Division of Clinical Immunology and Allergy, and the Chief of the Laboratory of Behavioral Immunology Research at the University of Mississippi Medical Center. Dr. Marshall and I have known each other for about 10 years, worked on a number of projects. There's really no one I've worked with that has had the breadth of academic exposure, be it basic research, clinical research, mentoring, design, administration. He really brings a wealth of a very long career of experience to his talk today. And his interest in psychoneuroimmunology, which he's been working on for a number of years, of mind-body interaction with the immunologic system, has really been groundbreaking. So today he's going to give a talk that tries to pull a lot of this together, entitled Integrative Medicine for Internists, Comprehensive Approach to the Whole Patient, and we're all looking forward. Please welcome Dr. Gailen Marshall.
Thank you, Steve. I appreciate it very much, and it's a pleasure to be here. And oh, by the way, sometimes I get to see patients, just so you know, with all that other stuff that's in there. And that's probably perhaps my most favorite thing to do. Now, it's been many years since I sat where many of you are sitting as a trainee, and I love the idea that you have an academic half day for learning. I also love the fact that I'm giving the suitcase memorial lecture, because as soon as I'm done, then you get to go back and do other things. So your mind may already be thinking, A, I'm a little saturated with what I have learned so far today, and B, I don't like the idea of giving herbals to my patients anyway, so I want to do some real medicine, so I want to move on. Allow me to ask you to give me about 15 minutes of your time with an open mind, and if in 15 minutes you say, this guy's still a nut, forget it, I don't want to have anything to do with it, then fine. Take a nap. You won't be called on. If you can sneak out of here and not get caught, it's okay with me as well. All right? Again, it hadn't been that many years since I sat where you're sitting. I remember. But the whole idea is that I would say you have to understand something about me. Just to tell you a very brief thing about me. I started out life as a basic scientist. And in the days that I went, you decided this. I went to college in the South. You decided pretty much your first year of college whether you wanted to go and become a physician or whether you wanted to become a scientist. The idea of a medical scientist in the late 60s was a very unknown quantity. So I decided the science pathway, and I indeed went undergraduate. I was a laboratory assistant. I went to master's program and a Ph.D. program. And when I was finishing my Ph.D., my research had taken something of a clinical type move. I'd spent time at the NIH, I'd spent time at George Washington in D.C., and the comment was, you need to go to medical school because it will make your research more relevant. Well, I'd already been to school for 6 years in graduate school, and the idea of spending another 4 years in school was not exciting, but I'd just gotten married. My wife was very open-minded about this, and I wanted to have a basic science career in a clinical department instead of a basic science department because the salary was better, and the opportunities for funding were probably a little bit better. So I went back home to Texas where I grew up, and I went to medical school in Galveston because they had a 3-year option. Then I could get out of medical school in 3 years instead of 4 and go back to the lab. And they had then a brand new program called Introduction to Patient Evaluation. And in the first semester of my first year, they taught me about how to interact with patients. And I say that to say is that I suddenly realized that the passion and love I had for basic science, I was going to have that same passion and love for taking care of patients. And in the 30-plus years since then, there have been a lot of times when I've been frustrated and anxious and discouraged, but I've never been bored, not a day in my life. And I came upon this very idea and this very topic because I've always been interested in the mechanisms of immune balance, in oncology, in cardiovascular disease, and I will give anyone my standing $10, which for an academic is a lot of money, a standing $10 prize if you can name me a fundamental disease that has nothing to do with inflammation. $10 for anybody that can do that. And oh, by the way, I've made that play. I used to do $100, but I got scared and nervous, so I moved down to $10. you won't be able to do it. Because there's not a single disease entity, category that doesn't have something to do with inflammation in one way or another, either as a cause or in some cases as an effect. Diabetics with a blood sugar of 300 have secondary immunodeficiency. They have neutrophilic dysfunction by definition because neutrophils don't do well when they swim in the syrup of a blood sugar of 300. Well, guess what? The same thing with that and all that thing. So I'm introduced to the idea that the mind could affect the immune system. And we have been studying that now for about 20 years, have been very successful in publishing and in funding. But the big thing is that what we've become more successful with is that there is this mindset out there that's been around a long time that says, guess what, folks? It matters in how we practice medicine. So that's the first 2 minutes of the 15 minutes I've asked you for, is to give you this idea. And this thing, does this not work? Maybe the battery's gone. If we can go here with this one. Okay. By the way, this undergraduate was Texas A&M. Never give a guy something with 3 buttons. It doesn't work. Ah, there it goes. I feel butter. Never put it in a cardiologist's hand either. So anyway, as we were talking about this, begin to talk about this, I think I'm supposed to tell you what my disclosures are, other than NIH funding, and that I do have one, it's got that there. There it is. I have research support from AstraZeneca for a clinical trial that we're finished, and I really don't have anything else to disclose that's relevant. We're going to talk about the principles of integrative medicine and how it applies to your patients and mine. And we're going to discuss the major components of what evidence-based medicine really means. You know, everybody's throwing that word around. And since you've been in medical school, it's, we only practice evidence-based medicine. We wear that like a badge of honor. Well, I have some comments about that as well. First of all, I'm not belittling that. We should only practice evidence-based medicine. But I want to talk about what the word evidence means. Okay? Health is the physical, emotional, and spiritual well-being of the individual. Anybody can argue about that? Mrs. Jones comes in and says, Dr. Marshall, I don't feel good. Well, Mrs. Jones, what's wrong? I'm not sure. I just don't feel good. And being the good internist that I am, so I take a better history. I get all of her social history, all of her past medical history. I examine her with a way from the top of her head to the tip of her toes. I order all the appropriate laboratory tests. Everything comes back normal. So I come back and I says, good news, Mrs. Jones. There's nothing wrong. Except Mrs. Jones didn't come to see me to find out that her physical exam was normal, her labs were normal. Mrs. Jones came to see me because she didn't feel well. Something was wrong. The whole concept is that it's more than just the absence of disease. And it cannot be attained solely through pills or procedures. It involves the initiation and maintenance of a fancy word called homeostasis, which just means balance. It's balance in everything that we do, and it includes both a psychological and spiritual components to all of our patients. Management of things like life stress, search for personal meaning, and life satisfactions. That's so-called quality of life measures now that I guarantee you, go talk to your hospital presidents. And they want to know about quality of life measures just as much as they do about how quick you can get them discharged on the morning of discharge, if they're out before 8 o'clock in the morning. Because that's what people decide that they feel well about. And it's as true for you and me as it is for the patients of which we care. Chronic disease prevalence is increasing, and we live in an increasingly obese and sedentary society. Mississippi finally lost the title as the most obese state in the country in July. Louisiana. Thank you. Yeah. And I figure we'll get it back. We'll get it back. We take care of, it is so unusual to see someone with a body mass index, and this is laughable, but it's not laughable. To see somebody in clinic with a body mass index of 21, we begin to worry if something's wrong because they are so thin. The average body mass index of Mississippi is so high that 78% of the population is overweight and 40% is clinically obese. And the worst scenario in it are children and young adults. It's not just old people whose metabolism is slowed down like me. and are just overweight and we don't exercise like we used to, but our dietary habits are not that much better than they were when we were your age. It's the kids and the young adults that are coming up. So all these diseases that are associated with obesity, you and I are going to be seeing more and more and more as these children and adolescents become adults that come to our clinic. There's increasing levels of societal stress, the horror of the mass shootings that are going on and the tension that produces. And that's just one of many examples of the societal stress in which we live and the cost containment strategies of health care are not working. It's still costing us more and more and more to take care of patients. Disparity continues despite many governmental efforts, and Western medicine is increasingly technology driven. It's important on your board exams. Sadly, the American Board of Internal Medicine exam will ask you for every one question about the psychological well-being of your patient in a given area. They'll ask you 20 mechanism-based questions. Does that mean that mechanisms are 20 times more important than the psychological component? I simply asked that question. This was something that was done back in the 60s by the then dean of Tufts University, and it's his way of rewriting the Hippocratic Oath. And I just excerpt this a little bit for your thoughts. I will apply for the benefit of the sick all measures which are required, avoiding those twin traps of overtreatment and therapeutic nihilism. I will remember that there's an art to medicine as well as a science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. I will remember that I do not treat a fever chart or a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. My responsibilities include these related problems if I'm to care adequately for the sick. This is something, the version of which all of us stood up and said when we raised our hand and recited the Hippocratic Oath when we graduated from medical school. I will prevent disease wherever I can, for prevention is preferable to cure. So the question then relates to what is integrative medicine. If you learn nothing else, and I'm running out of my 15 minutes, and I understand that, but if you learn nothing else, I am not saying that integrative medicine is another word for CAM, complementary and alternative medicine. I'm not making fun of any of that. I don't make fun of any of it, but that's not what this is about. This is not about saying you need to treat cardiovascular disease with more herbals. You need to treat cardiovascular disease with meditation and stress management, and they won't need their antiarrhythmic drugs. I'm not saying that at all. I'm saying that the approach is recorded from the earliest medical history. Hippocrates is famously known to have said it is far more important to know what person the disease has than what disease the person has. The human is defined in the terms of their components of body, mind, and spirit. Some people, particularly in this part of the country, like to use the word soul. But it's the same idea. An atheist has a spiritual component to his or her being. This has nothing to do with religious tradition or the absence of the presence of it. It has to do, and we'll comment about that more in just a moment. It is actually the original personalized medicine. And it puts the patient at the center and addresses the full range of physical, emotional, mental, social, spiritual, and environmental influences that can affect a person's health. The therapeutic goal is to treat the whole patient using whatever evidence-based therapy, whether it's conventional, complementary, or alternative, that addresses the patient's specific needs. Classical integrative medicine principles, this is more from Hippocrates. Let food be thy medicine and medicine be thy food. Well, we are all not arguing too hard about the dietary components of health, more than, and I'll have some data to show you in a moment, more than just number of calories. It's the kind of calories and when we take them that seems to matter. Walking is man's best friend. There is exercise matters. Anybody in here written an exercise or at least given an oral exercise prescription to any of your patients in the last 6 months? Anybody who's not? Let's ask anybody that sees patients. Is there anybody who says, nope, I don't do that. I don't need to do that. Well, you can't live in the deep south and need to do that because we all need to get more exercise. A wise man should consider that health is the greatest of human blessings and learn by his own thought to derive benefit from his illness. Does a positive outlook, does optimism in your patient matter in terms of their outcome of your therapy? I submit to you the answer is yes, and I'll show you data about that in just a moment. Maimonides, who was a famous physician in the 12th century, said that the success of relieving the patient depends upon an intimate knowledge of the total patient. And because of my pulmonary background, mental suffering impedes well-being and adversely affects the respiratory organs. What does the word dyspnea mean? Anybody tell me real quick? What does dyspnea mean? It's not a trick question. Dyspnea is a perceived difficulty in breathing. You ever seen a patient now, when somebody is pumping 40 breaths a minute, it's not too hard to tell that person is also tachypnic. But dyspnea and tachypnea are two different words, and they have two different meanings. A perception in difficulty in breathing. So is dyspnea always because of a direct physiologic problem with the lung? The answer is we all know no. You ever been scared? You ever been scared to death that something bad was going to happen, and it might have been after a car wreck or some experience, and you were pumping real good and you couldn't catch your breath and you had difficulty breathing? There's nothing wrong with your lungs. There's nothing wrong with your cardiovascular system. There's nothing wrong with your blood volume, but you are dyspneic at the moment. That was a psychophysiological driven event. So let's talk a little bit about neuroendocrine interactions and disease risk itself, because this is work that I've done over the years and our group has been involved in. The stress response, somebody says, I'm under a lot of stress. It's not necessarily the event. The event is better described as a stressor. Some people would consider what they're sitting here now listening as a stressor. The question is whether you are stressed because of this or not. The psychophysiological response to the event is the stress. Acutely, I'm under a lot of stress. The classic fight or flight response, which is hypophyseal, pituitary, adrenal, and autonomic nervous system mediated. It's often healthy, actually. We do this with exercise. And it's also perceptive. There may be somebody in this room, and some of you look physically fit enough that you might be one of these crazy people that strap a big rubber band around your waist and jump off of bridges. They call them bungee jumping. Well, for me, they would just find my body at the bottom of the bungee, whether it broke or not, because the very idea that I would do something would literally scare me to death. Same event, very different physiologic responses depending on what you want to do. In contrast, chronic stress, I'm really stressed out, moves itself to dysfunctional areas, maladaptive areas such as anxiety, chronic depression, anxiety, worry, etc. And it can relieve to what is described in the literature as either endocrine or immune exhaustion. And if you think about that, we all have what we have as younger people that we lose as we get older is that word reserve. In whatever physiologic system you want to talk about, we lose reserve. Well, that's true in the endocrine and immune system as it relates to chronic stress as well. You use it up, you use it up, you use it up, and then finally it can actually fail. The major factors that impact, and this is from the literature, the nature, magnitude, and duration of the response include outlook, an optimism versus pessimism idea, half full, half empty. Social support system, the nuclear family seems to be the strongest, but fraternal organization and community, and this is one of the things that in the challenge that some of our more senior folks in the room, remember people that we went to medical school with, and that they're still friends of ours, even though we may live in different parts of the world, we still keep up with them sometimes because we had these friendships early on in there. In today's medical school environment, oftentimes these kids see each other the first week or two of their first year, and then they never see each other collectively again because that's the way that it's structured now in the nature of educational psychology. And that's a whole different story. But one of the things that denies is the need of fraternity or community where education is concerned. There is a value of having your friends back. And they don't have to be your best friend for you to be able to looking out for them because then they're looking out for you at the same way. That's what that's talking about. And then this belief system of spirituality, the basic premise is that it's not just random. There's some purpose. And then the purpose is personally defined. It's not something that's predefined. How can the mind affect the immune system? Everybody knows about the basic Th1, Th2 ratio, and if there are immunologists in the room, you know how overly simplified this is. The important point that I would have is this right here, an immune balance, so that we can move one way or another. The classic immune balance, this tends to support cell-mediated immunity. This tends to support humoral immunity. So if you get a cold, and the cold infects the cells that need to be gotten rid of, you need cell-mediated immunity, and the immune response can move toward that direction, but then it comes back to balance. If you want to prevent the cold and you vaccinate somebody, they need more of a Th2 type immunity to make more antibodies, but then it comes back into balance. If they are genetically or environmentally changed, it is this cell right here, this regulatory component, that can interact with all these different ones. And I don't want to belabor this. I simply want to make the point that this one tends to live at the center of all this. And interestingly enough, with our work and others that have been published, this seems to be a main target of chronic stress in humans and higher mammalian groups. It produces this imbalance. And this imbalance can just as well be imbalanced that way as it can be balanced that way. And some of the immune hypersensitivity diseases, whether they're autoimmune or whether they're allergic, some of the things that you would think of. By the way, would you ever consider an inflammatory bowel disease as being an autoimmune disease? Well, the gastroenterologist would say, sure, it's an autoimmune disease. But then ask them what the inciting antigen is. If there's 5 of them in the room, you'll get 7 answers. Because nobody really knows that, but they do know it is an imbalance. And the end result of that is that you have people that have increased sensitivity to these various diseases. This pathway that has been worked out is, again, the perception of the stress working primarily through the hypophyseal pituitary adrenal axis and through the autonomic nervous system. There are receptors for all these hormones and epinephrine and norepinephrine on the surface of all these immune cells. And then interestingly enough, there are receptors in the central nervous system for all of the various cytokines associated with these inflammatory things as well. Everybody knows about sickness behavior. When you get a really nasty, bad cold, you're not really in the mood to be around a lot of people. Well, if you think about it, there's a teleologic value to that. If you're sick and you've got a high fever and you don't want to be around me, the chances of you transmitting that virus to me go down. That is related to the distance that we are from one another. And then secondly, you don't really want to interact with other people. You tend to be not really agoraphobic, but you don't want to be around people. You want to be left alone so that you can recover, and your body can then shift to putting more effort of the body energy into the immune response to more rapidly recover from you. If you've been sick and you just keep going, you just got to keep going and you keep going and you can't get well and you can't get well and you can't get well, there are good physiologic reasons to explain that. And this is part of that mechanism that helps explain it. This is just a couple things we did. This is a study we did. This was from the paper that we published in 1998 showing an imbalance associated with stress, not just suppression, where we took medical students 4 weeks before and right after their block exam. And in those days, all the medical students did everything together, so there were 150 kids that were doing exactly the same thing. So there was gender differences, age differences, even racial differences, and we could get away with that. What we did is that we looked at something called a daily hassle scale. It's exactly what it sounds like. How hassled are you today? If you had a high score, you were really feeling hassled. If you had a low score, not so much. And what we showed was that this balance that I showed you a moment ago was suppressed in the ones that had a very high hassle score compared to the ones that had a low hassle score. But the sheer magnitude of the stress. In these days, they all took their exams on Monday. It was called Black Monday because all of their block exams were on one day. So needless to say, nobody slept since about the previous Thursday. And they were working all weekend ready to try to get that stuff out. We all remember this in some form or fashion. So the sheer magnitude of this still pushed the ones that were doing well down almost as far as the ones that were not doing well from the get-go. This is this regulatory cell that we were talking about. And this is nothing more than what it sounds like. Again, the higher the score, the higher your perceived personal stress is. These are a number of normal individuals that had a relationship statistically significant that the higher their level went, the lower their regulatory cells went. So people with hypersensitivity disease, the take home of this is that the higher their stress is, the more that regulatory component, which may already be defective in them, is going to be assaulted by the stress itself. Here's a couple of studies that may be of some interest to you. This is a work-related stress, inability to relax after work, and the risk for onset of adult asthma. This was a study published now about 5 years ago, fairly large study. I mean, 4,000 people that were followed over a 10-year period of time. Asthma measured by stress reports, certainly a limitation of the study. And there were two scales, work stress, which was a surrogate that they used for an acutely stressful situation. I came to work and you start berating me because you don't think I'm working hard enough and on and on and on. Well, yeah, I have to put up with you for 8 hours, but in 8 hours I get to go home. And if I'm somebody who could just go pick up a fishing rod and go fishing and I don't care about it, I don't have to think about you again till tomorrow. And if it's Friday afternoon, I don't have to think about you to Monday, I'm good. So I have repeat acute stress, but I have low chronic stress. If I can't relax after work, all I can do is think about how much I hate my job and, oh, by the way, how much I hate you. And I lay awake thinking about this and so on. And I never sit close to me. People learn that early. And the end result of that is that they just can't relax. That's the surrogate for chronic stress. And the reason I bring this up is that I want to show it for you is that they looked at things like health-related lifestyle, how big they were in family history to assess that. What this showed you was that if the work stress and the acute was low, their probability ratio of developing asthma was the standard that they used. Over that 10-year period of time, even if they had a moderate level, they had a 45% increased risk. And if they had a high level, they had, it's hard for me to see this at that angle. They did not have at the moderate increase. It was only at the high level of acute that it was 45% in there. And the trend was there, but it's not particularly exciting. Just acute stress, no chronic stress, just acute stress, no chronic stress. There was an opportunity to recover. But on the other hand, if they had chronic stress here, 46% just in the medium stress, 84% increase there, and even when you adjusted for all the cofactors, it was still statistically higher. A relationship between the risk of developing an inflammatory disease and the level of chronic stress they're in. It turns out there's a literature here for cardiovascular disease, there's a literature here for cancer, there's a literature here for diabetes that are all associated with the same type idea. This is an interesting paper that I saw just from last year. This was 70 European Jews born in countries under Nazi rule during the period from 1940 to 45. They were interviewed to determine the presence of chronic diseases in an individual, and they were compared to 230 Israelis who were born in Israel and therefore were not subject to the same type of stress associated with the Holocaust. Look at all these different diseases and look at all of these. These are the individuals. This is from the 70 individuals exposed compared to the 230 not exposed. And look at all these p-values. Yeah, I can go down and make it easier for you for the ones. This is a trend but not statistically significant for asthma. There was not much for myocardial infarction, and there was not much. There was one more. Actually, this is a trend as well because it's not statistically significant, and stroke. But look at all these others. Hypertension, hypertriglyceridemia, hypercholesterolemia, angina, congestive heart failure, and other heart disease, lung disease, peptic ulcer disease, and so on, associated with a higher level of chronic stress. We all know the story of the Holocaust. We all know the stories of the things that people went through, either waiting to be captured or actually captured and interred in themselves. This is another study looking at, interestingly enough, renal dysfunction in adult men, that the link between metabolic risk factors, 1,230 Japanese office workers, their EGFR was estimated from their blood work, and job stress was measured with something called a job content questionnaire. And they were separated into job strain quartiles, lowest stress, moderate, high, and highest, 4 different groups. And they looked for correlations between the risk factors and hypertension. Triglyceride, in this one, the solid line is the highest quartile, and the dotted line is the lowest quartile. So here you have estimated GFR as the triglyceride level goes up. In the highest quartile, there is no improvement. Whereas in the lowest quartile, lowest stress level, there is an improvement over time in a statistical way. If you look at systolic blood pressure, the systolic blood pressure, the GFR goes down as the blood pressure goes up in the highest stress group, which is moderated significantly in the lower stress group comparatively. The same thing's true for diastolic pressure in the high stress group compared to the lowest stress group. Same matched, they're otherwise matched, and you could look at the paper to do that. And obviously, there's not enough time for me to do that for you. But the same group, they're matched other than the fact of this high versus low job stress group. What about the integrative approach to medical care? It takes more than 5 minutes. You can't do this in 5 minutes with a patient. You have to consider underlying issues such as the chief complaint and the modifiers. 75%, this is well recognized, 75% of all office visits of all physicians comers has something to do with stress. That's not something that we can readily ignore, and cofactors influencing clinical response like diet, physical conditioning, sleep, and other things are very important. And then you make an objective decision for the best evidence-based therapy, either conventional or complementary and alternative or both. And you have to address all three components of the patient. That, in a nutshell, is what you have to be able to do. What about its usefulness? Is there any evidence to go along with it? And this is the part I think I want to try to emphasize to you. Now, everybody knows about the Cochrane database for whatever, right? You get pushed back to that all the time. That's sort of the definitive thing if there's an area you want to know, because the Cochrane database that comes out of England is a very well done group of information that's done about as objective as any human can be. There's no such thing as total objectivity, but they certainly do a very good job to try to minimize any kind of bias, and they give recommendations. And what they talk about is that the evidence-based medicine triad is certainly the best external evidence, and that's what we all talk about. All we got to talk about, evidence-based medicine means clinical trials that are randomized and placebo-controlled. And yes, that's a part of it. But guess what? There is a value if you learning how to become a good physician. There's a value for you listening to your attendings and reading and gathering new information, because individual clinical expertise is part of evidence-based medicine as well. Name me a disease that there's only one choice for. Name me a single disease that there's only one choice for. There's not one. There's always a multiplicity of approaches and therapies, and they need our expertise to be able to decide which one is right for which patient. But then there's another piece that's very critical as well, patient value and expectation. It's very critical to understand that if our patients are not part of this evidence-based triad process, then we're really not practicing evidence-based medicine in the level that we should. Assessing the quality of evidence, and I think you've all seen these. Level 1 is evidence obtained from one properly designed randomized trial, not randomized, case-controlled study, multiple time series studies, uncontrolled trials. And another level is still the opinions of respected authorities. Opinion of respected authorities play a role, but it's not the same role as randomized so-called objective controlled trials. And then the recommendations that we make are the basis of this evidence. It goes from level A, which is good scientific evidence, says the benefits are better than the potential risk, and you discuss this with the patient and basically recommend the therapy for them. You get down to D, that basically says there's fair evidence that says the risks are worse than the benefits or outweigh the benefits, and you should not routinely offer the service to the patient and try to discourage them from using it. And then many of the things really truly fall into this one. Evidence is lacking or of poor quality or conflicting such that the risk versus benefit balance cannot be assessed, and you should help the patients understand the uncertainty surrounding the clinical service to be provided. And you say, well, yeah, if you're going to talk about herbs, I understand that, but how about half of what we do on a regular clinical basis? Anyone here ever tell somebody if they have a headache to take an aspirin? What's the clinical basis for that? What's the evidence for that? How many clinical trials have ever been done to show that aspirin has efficacy superior to placebo in the treatment of simple headache? I can tell you, at least the last time I looked at this, which was a week ago, there's nothing listed in PubMed. And PubMed goes back to the 60s. Would you say that most of us as experts have either ourselves experientially or through somebody else in prescribing to patients done some version of that and have seen that it has worked? And would you think that patients basically buy into the idea from the DTC advertising where Bayer aspirin is the #1 reliever of headaches in patients? They have a certain level of expectation as well. So you've got a small circle in best external evidence, a moderate circle in terms of large of individual clinical expertise, and a huge circle in terms of patient expectation. That is level I, and that's what we do. So When complementary or alternative therapies are offered up, too many times people stomp their foot, snort contemptuously, and say, there's no evidence to support that, except that things that we do every day to take care of our patients, the evidence is really quite limited. And we must be aware of that if what we're trying to do is to take care of our patients. Complementary means used together, alternative means used in place of, and remember, what used to be considered complementary is now, in many cases, taken as being useful for everyone. The NCCIH is the new name for NCAM, National Center for Complementary and Alternative Medicine, was renamed last year the National Center for Complementary and Integrative Health. So at the federal level, they think this is important enough that they've actually renamed that group. Treating vitamin D deficiency and asthma and other inflammatory diseases is one of the real hot things in our group, so much so that the asthmatologists now in the literature are saying that our classic level, remember vitamin D, anything below 30 and 20, between 20 and 30 is insufficient and under 20 is deficient. So now there are data to suggest that in fact that number needs to be pushed up to 40 instead of 30. And oh, by the way, that doesn't even begin to address the fact that, remember, to convert vitamin D to 1,25-dihydroxyvitamin D that's active, you need sunlight. And what is the number one absorber of the UV wavelength in sunlight in people? What is the number one absorber? Melanin. So, not surprisingly, dark-skinned individual, regardless of their race, the darker their skin tone, the lower their vitamin D level has a tendency to be. And African American and Caucasian, which is what's been studied the most and published on, the difference is there. So technically, a higher percentage of African American patients are vitamin D deficient. Well, let's go along with this also. A higher percentage of African American patients have allergic asthma. A higher percentage of African American patients have a more difficult to control asthma. Is there a relationship there or not? There's lots of people asking that question. But it is right now in the midst of complementary and alternative medicine because there is no fine guideline sponsored by or supported by the National Center of the National Institute of Heart, NHLBI, Heart, Lung, and Blood. Anyway, the NIH doesn't support that yet because there's not sufficient evidence to do it. So are we going to wait till we get evidence to make sure that our patients are not vitamin D deficient? Do we now check vitamin D in all of our asthma patients? I do. I check them in all my asthma patients now because I'm amazed at the number that I'm seeing that fall into the insufficient level. I'm not sure about moving them up to 40 from 30 yet, but I am sure about if they're between 30 and 20 they deserve to be treated. And have we seen a difference in that yet? Don't know yet. Probiotics and radiation-induced bowel disease in cancer patients. How about probiotics? Anybody in here tell patients to do something with their microbiome when they're taking an antibiotic for something? Does everybody do that? And the everybody do it can be something as easy, by the way, as making sure they eat good yogurt every day. That's what I tell my patients to do. Not to eat the ultra-pasteurized yogurt because the stuff's dead. But for everything else, to eat good yogurt while they're taking antimicrobials. So if you give them a 5-day Z-Back, how long do you have them take the yogurt? We have them take it for 10 days. The same argument because it's around biologically. That's complementary and alternative medicine. It's not established yet, but it makes perfect scientific sense and perfect logic for us to do things like that. It's widely used in Western society. 70% of our patient base are using CAM. And if you walk into the appointment with your patient with a contemptuous attitude, best case scenario, they just won't tell you what they're doing, which can have an herb-drug interaction, which can be a problem at times. Worst case scenario is they'll go find somebody else. Right now in training, you don't think of that as necessarily a bad thing. That just lowers my clinic load by one patient. That's okay. But there'll be someday when you will matter to that because that patient also has an insurance policy that contributes to you being able to make a living. So setting this now is, yeah, doing more work for yourself. Admittedly, that's true. But it'll pay off for you later on. There's different kinds here, and I'm not going through them other than just to mention them. Mind-body things, biological-based, nutritional-based, physical manipulations, and even energy-based therapies. And there's a literature for all of these, and they very much fall into the weak area of evidence as individual, single entity interactions. I see all the value of these more as complementary rather than alternative. There are not very many of these things that say, well, look, you know what? If I'll start practicing yoga 4 times a week, I won't need my blood pressure medicine. For some people, that will be true. But you don't walk in and tell somebody, Mr. Smith, you've got hypertension and you're on 3 blood pressure medicines. And if you'll start yoga in 6 months, you'll be off all of those. First of all, you don't know whether that's true or not. And second of all, you're putting a burden on that augmentative therapy that may improve his quality of life. And what if it gets him from 3 medicines to 1 or to 2? Have you actually improved him in a case like that? It has to do with that mindset and that idea. And then the therapeutic systems, traditional Chinese medicine, Ayurvedic, Native American medicine, chiropractic, and homeopathy are all care systems that are based upon different premises. This is a thought of looking at mindfulness-based stress reduction for solid organ transplant. And the idea was to assess the efficacy of stress reduction to reduce symptoms of anxiety, depression, and poor sleep in these patients. And this just shows you an idea. It's not a large study. There are about 70 plus in the 2 groups. And the intervention was an 8 weekly 2.5-hour sessions. Well, that's not very practical in the real world, but it demonstrates the principle. And then the control, the active control, was a health education group, which they had to sit and learn about health education for 2.5 hours. That would be stressful for me in and of itself. And the primary measures were the level of anxiety, depression, and sleep quality over an 8-week period of time. And what they showed is that the benefits were above and beyond those afforded to the active control in the MBSR, the stress reduction group, reduced anxiety and sleep symptoms with a medium treatment effect. That's not bad at 1 year compared to health education group. Within the MBSR, the improvement was within 8 weeks, and the benefits were retained for 1 year. Remember, it's an 8-week program, and then they're done. So they don't have to keep going for 2.5 hours every week for a year. It's a defined program. Our psychologists at Mississippi have developed a program that has shortened this considerably. It's 6 weeks, and it's only an hour session. And the data we're accumulating now say that it works every bit as well as this more classical 8-week mindfulness-based stress reduction. So the principle has been demonstrated in the psychology community. They're trying to make it more pragmatic. You're not going to find a whole lot of patients that are going to invest 2 months of 2.5 hours a week to do this. And oh, by the way, virtually none of them will their insurance pay for it. So they have to figure out how to pay for it. We're working on those things, and it's being done around in various parts. The initial symptom reduction in the health education group was smaller and not sustained. And the comparison of the impact of MBSR on both symptoms and quality of life, where health education improvement was only in quality of life as well. Now, what about diet? We talked about nutrition a little bit. What about diet? This is the classic study that was published in New England Journal a couple of years ago. 7,000 plus Spanish patients that had high cardiovascular risk factor but no previous cardiovascular event, no stroke, no congestive heart failure, no MI. Parallel group multicenter randomized trial into 3 groups. Control lower fat group, which that means we couldn't do this study in Mississippi, I think. Mediterranean diet, and I think everybody knows basically about the Mediterranean diet. High in grains, low in red meat, high in fish, and then high in oils like olive oil, unsaturated oils. That added extra amount of mixed nuts, almonds are a big thing that they like to give, or an extra amount, 1 liter a week of extra virgin olive oil. And they measured the endpoint, which was combined MI, stroke, and cardiovascular-related mortality. The study was stopped after 4.8 years because of the interim analysis, and this is the interim analysis up here. Cardiovascular risk factor, this is the control group, and what their death rate was over the years. This is the ones that were in the Mediterranean diet, whether they were getting extra virgin olive oil or extra almonds. The substantial decrease in mortality risk was so strong that they stopped the study. How many of you talk to your patients on a regular basis about that are not in cardiology clinic about their diet and the importance of their diet? And let me make it even stronger. How many of you do it out of a position of really knowing what to talk about, what the data are? I don't think you probably get a lot of nutrition lectures in your academic half day, other than the idea of calories in minus calories out, which of course is overwhelmingly silly and naive to suggest that that's all the answer. If you want to lose weight, just eat less. That's all you need to do. That's what everybody says. And it doesn't work. And when it doesn't work, then people give up, or they punish themselves with a diet, and then they gain back everything they worked before, and they do this yo-yo, which has been shown over and over again to have very severe health consequences associated with it. To show you that it was cardiovascular related is that they also looked at combined cause of all causes of death, and there was no statistical difference between the three groups here compared to this. This just shows you the importance of diet in managing severe cardiovascular risk. This is another one that showed 6 weeks of yoga therapy. Yoga has, in essence, 3 components that go nicely with it in other forms of stress management. Stretching, so it has a physical component, breathing exercises, which are very important in a calming effect, and a meditation component, which is useful as a psychological stress manager. And I'm not belittling that that's all yoga is. I'm saying that's the components that it takes and puts together in a single system. Candidly, for many, many people, it's a very nice system that works very practically. For other people, less so. But this just shows you some of the parameters. This is the people before versus after, and the reduction of their blood sugar statistically. Look at all the statistics down here. Blood sugar going down, postprandial blood sugar going down, total cholesterol, total triglycerides, LDL, VLDL, all of these things here, all these risk factors, cardiovascular, in diabetic patients, just from participating in yoga once a week for 6 weeks. So is this going to continue if they stay in yoga once a week and do it for 6 months? Study hasn't been published, so we don't know the answer. But is there going to be any harm to them? It looks like the answer to that is no. What about people that want to do herbals? And you say, but I don't know anything about herbals. I simply use this as an example. There's several of these, and this one is the one that I happen to personally prefer because of its ease of use. And it's got a natural database that you can go in and say, all right, I want to know if a drug, a given herb that this patient either wants or is taking, is it going to have, I want to prescribe this medicine for them, is there going to be a problem with herb-drug interaction? You can get that information off this site. What about is there one that I should recommend to a patient who comes in and says, doctor, I want a more natural approach to my asthma? They have this component as well. And I just use this one because I'm an asthma guy, and this is what sort of thing we do. It becomes very easy for you to see this. This pops up on your screen. Here are the ones that they clearly recommend based upon the evidence. Guess what? There's none in there. Here are the ones that they say don't do, usually because they're dangerous, and there's one in there because of it's unsafe. And it can go all the way. If it's down here, you want to take time to tell them don't do this. If it's up here, you want to take time to say, okay, most of these things, because of the limited evidence, are here in the middle. You can have this for hypertension. You can have this for cholesterol control. You can have this for gout. You can have this for virtually any clinical indication. Finally, just a word or two about spirituality and health. Spirituality is defined as the way people find meaning and purpose and how they experience their connectedness to themselves, to others, to the significant or the sacred. It is a universal human characteristic. One's relationship with the transcendent expressed through attitudes, habits, and practice. Manifestations may be religion, may be art and humanism, cultural beliefs, and practices. It is the inner life of a person. So by definition, all of us have a spiritual side to us. Some it may be in a traditional organized religious fashion. Others it may be in a more existential fashion. This was an oncologist who a few years ago showed that you could do spiritual diagnosis from the medical history. And he goes down here with different things like existential concerns, abandonment by God or others, anger at God or others, concerned about relationships, and then manifestations over here. Now you say, I have neither the time nor the interest to do that. Not saying you have to do it, but maybe you can refer them to somebody who does have the expertise. I consider myself still to be a competent internist. I'm a subspecialist in allergy, asthma, and immunology. But if I hear someone who's got severe cardiomyopathy who comes in to see me because they think their asthma's worse, they've got crackles up to their shoulder blades, and they've got a blowing S3 and S4 that is so loud it's hard to hear the 1 and 2, I'm not going to sit there and try to take care of that patient personally. I'm going to get them to a cardiologist who is more focused on what it's doing. I can recognize it, I can understand it, and if I was out somewhere where there was nobody else around, I could probably begin to try to manage it. But I'm going to send them to the subspecialist who is more tuned in that. The argument is that these kind of subspecialists exist as well. This shows you the issues related to all-cause mortality. This is something called an MMPI, that I think most of you know what it is. Optimism versus pessimism. This was a college group at the University of North Carolina 40 years ago that they enrolled in this study, and all they did was keep up with them to see how many of them would die of different causes of mortality, but they were all given this MMPI, and from that, they developed those who had, who were considered to have a low pessimism, high optimism, somewhere in the middle, and a high pessimism, low optimism, and they looked at the mortality rate, the survival rate really, over the next 40 years. And the lowest group were the pessimists compared to the optimists. Now, if you're smart at all, you look at this and say, oh, that's only 5%. Well, it's only 5%, but 5% ain't chicken liver if you have other risk factors to go along with it, because this was all comers. This was another study they did that looked at the same thing about flourishing, which was their idea of a positive mental outlook. And they looked at the risk factor for all-cause mortality if they were not flourishing, ergo they were pessimistic, compared to other things like chronological age, being male versus female, educational level, being black versus white, being other race versus white, being a cigarette smoker, and having cardiovascular disease. The relative risk factor from death from all causes was always higher. But it's not trivial that a high 67% increase for mortality was associated with a pessimistic attitude. So finally, this is a study, a quick study that I'll show you that was done very interestingly because it relates to therapeutic response to a severe cancer. This was a prognostic value of personal spirituality. They weren't making them spiritual, they were assessing their level of spirituality. In a small study, looking at patients responding to cancer chemotherapy in advanced non-small cell carcinoma. We all know that advanced non-small carcinoma doesn't respond well to chemotherapy at all. This was their faith score criteria. They asked this question as a yes or no, and each positive response got them a 20% rating. Adequate and conscious knowledge of the diagnosis and prognosis that they might not survive this. No excessive anxiety. They were more stoic about it. Lack of an excessive tendency to understand the mechanism of the disease and the chemotherapy. Before we proceed, you've got to make sure I understand. We wanted that you've all seen patients like this. They want to have the same level of knowledge that you do before they're willing to commit to moving on to the next step. No illusion regarding the ability of the clinicians, that the Dr. Marshall is not some magic clinician. He's a capable and competent clinician, but this is my disease, this is my problem, and he's going to try to help me to the degree he can. The perception of the disease is both a personal problem and a sign of the suffering human condition. And the patients were divided into either high group, high level of faith index, greater than 3 of these answered, or low, less than 3 of these answered. And what they looked at, and I think you all know this, complete response, partial response, considered a positive thing. This was all comers in that group. Only 30% had it. 36% had stable disease, and 34% were progressing. If they took them and took the low faith group compared to the high faith group, 4% compared to 21, 12 compared to 25, 16 compared to 46 in good response, and then in the progressive disease, 46 compared to 25. Small study, not definitive in any way, but it speaks about the idea of us at least addressing that. Is it our job to proselyte these individuals and help them with their spiritual development? Not necessarily at all. Is it our job to understand that it may be a component that could affect the outcome of our patients? Absolutely yes. And then get them to the person or people necessary to address this for them. So our conventional assessment, everything that we do commonly to take care of patients becomes appropriate. But a psychological assessment to identify underlying psychosocial stressors, to address perceived stress, worry, anxiety, and depression, either directly or indirectly. Same thing with spiritual assessment, meaningfulness and satisfaction with their life, and evidence of existential disturbance or crisis. And from that, construct a comprehensive management program that is sensitive, respectful, and non-judgmental in its approach, that is specific, conventional, and CAM interventions as indicated, and appropriate referrals, which may be to other medical subspecialists, to psychological professionals, or to spiritual professionals. The integrative medicine internal care is more than just complementary and alternative medicine. It's evidence-based for the entire patient, their body, their mind, and their spirit. More research is clearly needed for this. This is unfortunately very old, but it's also very new. And finally, many with low side effects but strong therapeutic potentials exist. Remember, our first dictum is, first of all, do no harm. Keep the patient safe. Don't automatically use a treatment, and don't automatically refuse a modality because you're unfamiliar with it or you have a preconceived notion. If we approach that, I would argue that we will someday drop the word integrative from a medicine approach to care, because that will be the standard medical approach that we have for all of our patients. This is a way to show you what my grandson likes, because there was a Jewish king 3,000 years ago who happened to record the words that a happy heart is good medicine and a cheerful mind works healing, but the broken spirit dries up the bones. The fascinating part is that that 3,000-year-old Hebrew king happened to know that the immune system starts in the bones. With that, I thank you for your attention, and whatever time we have, I'll be happy to answer questions. It's hard to have questions after you've been sitting for all these hours.
Anything about your own practices, how you would see working this in, or having barriers, let's say, to work this into what you do on a daily basis?
Any website that has general guidelines about using these herbs and everything?
Website?
Yeah.
There is actually a group called the Consortium of Academic Health Centers for Integrative Medicine. It is 54 different medical centers around the country, places like Harvard and Mayo and UC San Francisco, and soon University of Mississippi Medical Center. And each one of them, you can go to each one of their sites that offer different kinds of services, and they have collective information. What is integrative medicine? How do you go about it? And so on. I will be happy to send that site to Dr. Geraci, and he can distribute it to you all. Very, very useful site to go and look at.
Anything else? Okay, thank you.